Hi, good morning, everyone. Thank you very much for your attendance today. I'm just going to speak a little bit as some people trickle in, but just a few housekeeping issues. If everyone could please stay on mute, our team will be looking for any hand raising. We'll be looking through the chat the entire time, and we promise we will acknowledge, address, and field some questions to our surgeons and Dr. Pierre and Dr. Brian today. We'd greatly appreciate that. Just so everyone knows, in case you do want to come on camera for this meeting, this webinar will be live recorded and will be uploaded to our YouTube channel within the next couple of weeks. So just keep that in mind if you want to come on screen with us. And I would also like to introduce myself because I sometimes do not. My name is Edith. I am a physician assistant. I have had over 16 years of experience working in the neurotrauma ICU and in bariatric surgery. I have worked with IIH Hub for the past 2.5 years, and I will be moderating this lecture. So thank you all for joining this morning. Also, before we get started, I do want to take a moment to talk about September. It is dedicated to IIH Awareness Month. As we all know, IIH is idiopathic intracranial hypertension. It is a rare neurological disorder that predominantly affects women in their childbearing years. It can also occur in men and in those with a normal or under BMI and without fully meeting the DANDY criteria. So here at IIH Hub, we're striving to promote attention to this condition, early education, proper intervention, early diagnosis, and of course, research for this condition. With that being said, I'd like to go ahead and introduce our two speakers. We have Dr. Pierre Gobin and Dr. Brian Snelling. Dr. Gobin is a world-renowned neurointerventionalist. He now works at Weill Cornell Medicine in New York. He has more than 30 years of experience in treating cerebral vascular conditions. He has also pioneered research in the causes of IH, such as venous sinus stenosis. We also have Dr. Brian Snelling. He is a neurosurgeon and endovascular surgeon at Baptist Health in Boca Raton, Florida. He has over 12 years of experience in the treatment of neurovascular disorders, including some of the procedures used to treat and manage IIH. So thank you both for joining us today. Thank you.
Glad to be here.
Thank you. Today, we wanted to call our webinar Questions Answered on IIH, and specifically to the topics that deal with neurointervention and neurosurgery. So one question that I thought was pertinent will go to Dr. Brian Snelling. We do know that the placement of a VP or LP shunt is common for those who have IIH. So I wanted to see if you could just give us a few minutes for those who maybe don't understand or don't know or are new to this about the difference or what a shunt is and what the difference is between an LP and a VP shunt.
Yeah, certainly. So a shunt is basically, the simplest way to think about it is it's plumbing. The brain makes about a soda can's worth of brain and spinal fluid every day, and it circulates it around the brain and around the spinal cord, and then it's reabsorbed. So we've all been doing that our whole life. So we make this brain and spinal fluid, we reabsorb it. In certain conditions, there are times when that fluid is produced too much or can't be reabsorbed, or in the case of patients with IIH, where removing that fluid is a mechanism to reduce the overall pressure inside the skull, that placing a shunt becomes a beneficial surgical option. So like I said, it's quite simply some plumbing. A VP shunt stands for ventriculoperitoneal shunt. Ventricular means the ventricles, which are just the spaces inside the brain that produce brain and spinal fluid. And how that's done is it's a surgical procedure done by neurosurgeons. A catheter, which is a rubber tube, is placed into those fluid spaces, and it's connected to a valve, and the valve determines how much fluid, so what pressure fluid will drain from the skull into a tube that runs under the skin, down into the spaces around the organs in the abdomen, which is called the peritoneum, which is why it's called a ventricular peritoneal shunt. And that what that essentially does is it helps in the case of IIH, it helps to lower pressure in sort of the intracranial pressure and the pressure in the skull, which can improve patients' symptoms of headaches. And most importantly, it reduces the pressure on the optic nerves and reduces the chance that patients can have vision loss or deterioration in their vision from IIH. Another way of achieving the sort of the same end goal, which is to remove this fluid, is what's called a lumbar peritoneal shunt, or LP shunt. That is traditionally done by placing the catheter not in the fluid spaces of the brain, the ventricles where it's made, but actually placing it around the nerve roots in the bottom part of the lower back. So it's almost placed in a similar location as someone would have a lumbar puncture or a lumbar drain. And that catheter is again connected to a pressure valve. And then that pressure valve, which regulates how much fluid can leave, is then connected to a similar tube, which ends up in the fluid spaces of the abdomen. In the sense of doing this for IIH, traditionally LP shunts were thought to be beneficial, and that was really two reasons. One is that shunts were designed about 70 years ago at this point for patients that couldn't reabsorb enough of brain and spinal fluid, but we use them for another reason in patients with IIH, and that's to relieve that pressure. So patients with IIH aren't actually making too much brain and spinal fluid or reabsorbing too little. So those fluid spaces are actually quite small. In many places, they're actually compressed. And a lot of patients, when you look at their imaging, whether that's their CT scan of the brain or their MRI, you'll often see the radiologist report that they have what are called slit ventricles, meaning the ventricles themselves have been compressed from the actual pressure in the intracranial vault. So what that means is if the ventricles are slit, the place that the shunt catheter can go is actually quite narrow, and it can't free float within that fluid space. And as I said at the very beginning of all this, a shunt is essentially plumbing. So if the plumbing tube sits in a very tight location, there's a good chance that it can become blocked, that it can stop working. So that's a reason why people may not want to place them. You may think, oh, we don't want to place them here. We should rather place them in the lumbar area, because that area doesn't have that chance of getting blocked in the small ventricles. Additionally, patients on the outset would feel more comfortable having this procedure where someone's not drilling a hole in their skull to place this catheter. So it seems like it's a better idea. I would tell you, at least in my practice, and I think as the field in general, a lot of neurosurgeons have moved away from LP shunts, most commonly because they're very difficult to adjust, meaning the shunt valve itself, we can usually adjust those with a magnet that's outside the skin. That's very easy to do if your valve is sitting sort of fixed on top of your skull. It's easy to find, easy to adjust based on the patient's symptoms. That's much more difficult, if not impossible, to do if it's free floating in the soft tissues on your side or in your back. Additionally, the needs to revise these shunts, because they break down, at least with lumboperitoneal shunts in this population, seems to be higher than with VP shunts. So, a lot of times I think we've moved away from doing a lumbar peritoneal shunt to doing a VP shunt. A couple things I would say, if that's something that's being recommended to you as a patient, there's a couple things that you should look for. Number one is there is good neurosurgical data that shows that patients do better, and there's a lower rate of revision if the neurosurgeon uses the assistance of a general surgeon who can do laparoscopy. So meaning that the tubing that's placed from the valve under the skin into the fluid spaces around the abdomen, instead of doing an open incision in the belly, if a general surgeon can use a laparoscope and make several small sub-centimeter incisions and use a camera to place that, we know that those shunts last longer and they're less prone to breaking down. So if this is being recommended to you by a neurosurgeon, one question I would say is, well, do you do this procedure with a general surgeon who does this laparoscopically, which they should, because that's better for the patient. And number two, because if you are recommended to have a VP shunt and these fluid spaces are very small, again, we usually call them slit ventricles, the best thing to do is to place the catheter with some sort of stereotactic guidance, meaning it's almost like a GPS for the brain, meaning we use a special system that allows us to put the catheter with sub-millimeter accuracy in precisely the exact place it's supposed to be. Traditionally, the fluid spaces are big enough that most of us neurosurgeons trained how to do this freehand, just like with some landmarks on the skull, and we could freehand them into that space. Those techniques are much more prone to failure in patients with very small ventricles. So making sure that if you have this procedure, that hey, this is done by somebody who was able to place this catheter with this sort of stereotactic or what we call GPS guidance, or two ways to make sure that you're getting the best possible procedure performed. I hope that's not too long of an answer.
No, thank you very much. In fact, like I said, some people joining us, I see a lot of familiar faces. Thank you everyone for joining in. Dr. Snelling was just going over the difference between an LP and VP shunt because that is a very common procedure in those with IIH. And he was just giving an explanation because we do know that everyone is in a different part of their journey. Some people have been diagnosed for a long time. Some people have a lot of symptoms but haven't been formally diagnosed and they're searching for answers. And some people obviously know a lot of this information. So we want to tailor it to everyone. So we always appreciate that information taken from the bottom up. The next question is for Dr. Gobin. We know that venous sinus stenting has been in the last 10 years, like very promising, especially those who have IH and are found to have venous sinus stenosis. Could you just briefly talk about what are some indications or what patient would be a good candidate to have a venous sinus stent placed?
So, venous sinus stent the indication will be similar to the indication of performing a CSF shunt, the procedure that Brian just described. It should be no more, no less. Patients who are resistant to medical therapy or who do not tolerate their medication and still have severe symptoms, and the quality of life scales in patients with IH are really diminished a lot. They are really bad. So those patients, the same patients who will benefit from a shunt will benefit from a stent. With the added caveat that no stent is currently approved in the US for the indication of IIH. So we use stents that are not made especially for this disease. I hope this will change fast, but so far this is what we are doing. So basically we can stent patients because they have intractable headaches, because they have severe pulsatile tinnitus, because they have papilledema or loss of visual field or eye symptoms that are not relieved enough with medications. So that will be the indication for surgical treatment, including stent or shunt.
Thank you very much. I just saw a question on our chat from Miss Alicia. Thank you for joining us today, and thank you for streaming us through your platform. Her question is to Dr. Snelling. Can you have a working shunt and a high pressure after so for example, she has an LP shunt and she had a spinal tap done recently, and it shows that her pressures are still high. Is that possible?
I mean, without knowing the particular details, I would tell you that it's possible. I would, usually with shunts, the goal is to lower the pressure to a level that we think is normal, right? So maybe less than 20 centimeters of water. And if you have an LP is actually putting a needle into that space and it can actually give you an actual fluid measurement. So an LP gives you the true value of what the pressure is in the brain and spinal fluid compartment. And can you have a shunt that's working? It's certainly possible. It may just be that the shunt may be at a setting where it's not draining enough fluid. That's one possibility. Certainly, maybe this is less true for LP shunts, but certainly with VP shunts, sometimes they can drain too much or too little fluid based on whether they have a siphon guard, meaning there's an extra little piece of technology that you can put in that when patients are lying down or recumbent versus when they're sitting up, sometimes patients can overdrain. So that prevents that. But certainly when you think about it, after I just explained all that, it's a good question, right? So how can you have a shunt that's supposed to be lowering my pressure, but then I have an LP and my pressure's high? I guess the best way I would answer that is I think that's a great question for the neurosurgeon who plays the LP shunt, because without knowing the particular details, it's just a little bit of conjecture from me.
Thank you. Thank you very much. The next question is for Dr. Gobin. We have a patient who had a venous sinus stent placed 4 months ago. She had a repeat imaging, and it shows that her gradient is 4. However, when she went back to see her neuro-ophthalmologist, he still sees evidence of papilledema and actually placed her back on Diamox. And she's a little confused because she was under the impression that because she feels great after the stent is placed, that she thought maybe what she's read, that papilledema should resolve quite rapidly after the stent is placed.
There are several levels of intensity of papilledema, and you can have no papilledema at all, that having papilledema 0, and that's the normal, that's perfect. But having a papilledema of 1, yes, it is papilledema, but it's so mild that it doesn't have long-term consequences. So it would be useful to know how much papilledema she has, because if it's just 1, it's not a big deal. Then I don't know what type of, I suppose if this patient had imaging and that showed that the transvenous transstent gradient was 4, it means that there is no significant stenosis within the stent, so that the stent did its job of treating the narrowing, the stenosis of the venous sinus here. But maybe there is another stenosis somewhere else. Often patients with IIH develop multiple stenosis, and they may also develop stenosis on a sinus called the superior serratal sinus, which is the big sinus going from the back of the brain all the way anteriorly on the midline. And patient may develop this stenosis also, and so the best way to diagnose a new stenosis will be an MR venography with contrast. Then the last point is that stent doesn't cure IH. It relieves, I mean, it cures the stenosis. It improves a lot the symptoms, but it's not a cure of the disease itself. We know, and it is a recent hypothesis that is being confirmed by more and more imaging studies, that IH is due to something that is called lymphedema. Edema means swelling, and it's swelling of the intercellular space, what we call the interstitial space, within the brain. That's why you have a high pressure in the brain, but there is no tumor, but the ventricles are collapsed, and venous sinus stenosis form because the sinuses are swelled up, and the arachnoid velocities that drain the CSF and the interstitial fluid are also protruding. So when we do the venous sinus stenting, we treat only the venous component of the disease, but we do not address the lack of drainage of the brain fluid, of the interstitial or intercellular, if you want, brain fluid. And if we could treat this by some medication, or that will be the perfect treatment of IH. We do not have the perfect treatment of IH. We can relieve pressure by putting a shunt, by putting a stent, but the primum disease, we don't know how to address it yet.
Thank you very much. The next question from the chat is from I Hope to Dr. Snelling. What is your experience with LP shunt placement, and what's the long-term outcome? Things like, you know, failure rates, replacements, etc.
Sure, I would tell you my anecdotal experience is low because I tend to use VP shunting for the vast majority of my shunting procedures, and that's for two reasons. One, like I mentioned, shunting works for patients with IH, even though they fall into a very small category of all the patients that shunting is beneficial for. So for the vast majority of patients, shunting works quite well, and it has a quite low revision rate and whatnot. So it's just something I'm more familiar with and I'm more comfortable. I think LP shunting is a little bit more cumbersome unless people do it quite frequently. And like I said, if you want to use sometimes you can use a fixed pressure valve, meaning the valve can't be adjusted. It drains a certain pressure continuously. I tend to use valves that are adjustable. So I think those are a lot harder to place and to find in that space. I think they're much easier to find when they're affixed to the skull. And then the other reason, as I mentioned, is that I think a lot of the concerns about the need for revision with VP shunts mostly related to accurate catheter placement, meaning, okay, can we place this catheter in a perfect position within these small ventricles? I think a lot of that is mitigated by use of stereotaxis, by use of stereotactic guidance. So at least in my hands, that's something I'm more comfortable with. I think if you want to say, well, what's the long-term outcome from LP shunts? I think you'd have to go back and look at the literature. Again, the revision rates, depending on the study that you look at, can vary widely. Maybe they're 18% and maybe as high as like 85%. But a lot of the need for revision depends on the cohort of patients. So I'm not sure there's been a great study that says, look, for this specific cohort of patients with IIH, here's a long-term study of patients who have had LP shunts and what the revision rate is. If perhaps that's out there, I haven't been able to find it. But I do know that in general, the revision rates for shunting, whether VP or LP, those rates of revision are generally higher than they are for people with other cerebrospinal fluid disorders.
Thank you. Thank you very much. We had a question here from Ariane. The comment is, we really only hear about the visual impairment impacts on IH patients, but are there any other impacts such as cognitive function that we know about?
Do you want me to answer, Edith?
Yes, whoever, either of you.
Brian?
Go ahead, Pierre.
Yes.
You're the expert.
This is very, you are. This is an essential question because IH has been diagnosed and has been really a field of neuro-ophthalmologists who are seeing the disease as an ophthalmic disease. And it is true that the IH has a big impact on the visual function, on the eye, because you can lose vision with IH. If a papilledema is not under control, the patient may lose progressively visual field. And before we had treatment of IH, some patients were becoming blind. So the impact of IH on the eye is very important. But if I dare say, looking at IH only on its impact on the eye is missing 90% of the disease. Because IH induce headaches, induce pulsatile tinnitus, induces brain fog, and overall, a very poor quality of life. What we saw in the River study And the River study is a study that Serenity performed and submitted to the FDA to gain approval of a River Stent, a stent specially designed for stenting the venous sinus. And what we saw in this study is that the quality of life of patients were tremendously improving after venous sinus stenting. And this was in patients who had papilledema at baseline and also patients who did not have papilledema. So if you imagine that there is this high pressure in the brain due to the fact that the fluid in the brain does not drain normally, and then this can have an impact on the optic nerve and because of that, give some eye symptoms. But there are some IIH without papilledema. There are some IIH where the patient is miserable, but do not have any kind of visual effect of IIH. These patients, they do have IIH, and they deserve to be treated as much as the patients who have of the eyes, the visual signs of IIH. Does that answer your question?
Yes, thank you very much. Yes. A couple of questions, even when we polled on Instagram for either or both of you, is what form, type, or recommended exercise can be done after a shunt placement, after, you know, a stent placement, things like recovery, or maybe things to look out for or completely avoid, just as a general, you know, what you tell your patients after your procedure is over?
Sure. I'll tackle shunting, and Pierre can talk about a stent or however you want to do it. You know, shunting is a neurosurgical procedure. So generally, you know, you're going to have multiple incisions. You're going to have an incision in the scalp, and then you're going to have one, or like I mentioned, if you're having it done laparoscopically, multiple small abdominal incisions. So patients are usually in the hospital for at least a day, if not more, depending on their symptoms. You know, certainly if this is a planned procedure and everything goes well and we're not concerned about the patient's vision, then perhaps sending them home the following day is reasonable. But if you're really concerned that we're doing this in the setting as an emergency or whatnot, obviously you're gonna have to stay in the hospital a little while longer to confirm that the shunt is working and that, you know, your vision has either improved or hasn't continued to deteriorate. In terms of what you can and can't do, you know, for the first few weeks afterwards, you have the incisions are healing, and there's generally no, at least for me, there's no hard and fast restrictions of things you can't do, but most people aren't going to feel like doing much. You're recovering from a procedure. Patients are going to be sore. The tubing that's placed here, you know, they're going to have some headaches. Most people take Tylenol for that. The tubing has to be placed under the skin, so we use a device, a tunneling device, and that causes a lot of discomfort around the neck, over the chest, and into the abdomen. Sometimes patients can have a little bit of discomfort in the abdomen after having the abdominal portion of the procedure done. So again, people don't really feel like doing much for a couple of weeks. At your 2-week mark, you'll come back and see your surgeon. They'll look at your incisions to make sure everything's healing well, and then make sure that, you know, your postoperative pain is improving. Right, we want that to become less and less and less every day. The amount of medication you're taking and how you're feeling. And usually at the 2-week mark, patients sort of get cleared to start returning to more and more normal activities, like, okay, is it okay to go back to work? Can I start exercising? And all of those things are usually in moderation, right? So if you're going back to work, you know, you're not maybe taking on a half day as you get started, or at least with exercise, you know, you're not going to go back in the gym and start working out pretty aggressively. You're going to want to start taking some walks and all of those things. And most of those recommendations are general, are common to any sort of surgery. So they're not going to be specifically related to a shunt procedure. And then additionally, as in all of these things, you know, whether you're getting a shunt or a stent, you're going to have close follow-up with your ophthalmologist, because obviously, whether you're getting a shunt or a stent, we're doing this because you failed medical management and your vision's continued to decline, your papilledema hasn't improved, you can't tolerate the medications, and we do want to have, you know, objective evidence that either your vision's improving or it's stabilizing, it's not getting worse. So, you know, continued follow-up additionally with your ophthalmologist is certainly part of your postoperative plan.
Thank you. And Dr. Gobin, what sort of advice do you give to patients as far as going back to their normal lives, recovery, exercise, work, all that after placement of a stent?
So after placement of a stent, you will have a little incision in your groin where the vein was punctured to access the venous sinus of the brain, and you may have also an arterial puncture, a puncture of the artery in the groin or in your wrist. Many physicians like to have an angiogram when doing the procedure, so they do both an imaging of the artery and an imaging of the veins. So you should take it easy during 48 hours after the procedure to let those two incision sites heal completely. And after that, there is no real limitation of what you should do, except maybe during the first 1 to 3 months after the procedure, where you will be on the blood thinning medication called antiplatelet therapy. And during the first few months, your physician is going to give you 2 antiplatelet therapy. It's called a double antiplatelet therapy, DAPT. So during that time, during that 1 to 3 months, it depends on the protocol, it depends on the physician, but they will give DAPT for 1 to 3 months. Then you should avoid any sport where you could injure yourself because of risk of bleeding. But no, there is no other limitation. And after the initial period, most physicians will leave their patient on aspirin only for 6 months to 1 year. So during this time, some people are very sensitive to aspirin and may have bleeding and may have bruise on their skin when they are just on aspirin, but many patients will not.
Thank you very much. And along the same lines, Miss Natalie from Ontario, she said, or she's asking, how common is it to have 2 venous sinus stenting procedures on both sides? And what is the average recovery time from symptoms like headaches, fatigue, disorientation, etc.?
So I will not recommend, or maybe in some exceptional occasion, but I will not recommend placing 2 stents on both sides at the same time. I think it's taking an unnecessary risk. At Cornell, we will place 1 stent, and then if the patient doesn't improve enough, if there is still a high pressure in the brain, a high gradient, maybe because the 2 venous sinuses may drain different structure of the brain. One may drain the deep part of the brain, and the other may drain the superficial part of the brain. There are many anatomical variants there, so that could be a reason to place a second stent. But usually 1 stent is enough. With 2 stents, you go already in the rare cases, the complicated cases. Do you agree, Brian?
Yeah, I mean, I think that's, as you mentioned, you're usually, I mean, as we've highlighted in all of our physician talks, you're usually looking for the dominant system. So which side is dominant? And then that's the side that's, even though you see stenosis on both sides, then stenting, the dominant side is usually going to be sufficient to provide symptom relief and relief from the gradient.
Now about recovery time, I'm reading the chat from Natalie. Most of the recovery will happen during the first 3 months. What we saw in the River study is that most of the improvement was observed during the first 3 months. Improvement in headache, papilledema, pulsatile tinnitus, brain fog, quality of life. And then after 3 months, there was still improvement up to 1 year, but this improvement was slower. So most of your improvement, you should have it during the first 3 months.
Thank you very much. Thank you. I have a question I could ask Dr. Snelling. Can IIH cause convergence insufficiency and oculomotor dysfunction? She or they are saying, I did not have papilledema, but my journey began with functional vision impairment. And since I've had 2 stenting procedures.
Yeah, I mean, I'm not 100% sure about convergence insufficiency. That sounds like more of a ophthalmological diagnosis, so I'm not an ophthalmologist. But certainly, it can cause oculomotor issues, and it basically gets back to how what nerves are exposed to the pressures of the brain of the brain. And so we commonly worry about the second cranial nerve, or your optic nerve, for a couple of reasons. One, it controls your vision. And so for those of us, when you see the ophthalmologist, or for most people's symptoms, that's something we worry a lot about. And if you were to look anatomically at the optic nerves, they travel with exposure of the nerve sheath itself, or the sleeve, to the brain and spinal fluid for a long distance. And that's the reason that, they can be exposed to those high pressures. But there are other nerves that travel, other cranial nerves that travel a similar distance, or similarly long distances, that put them at risk for exposure or compression from increasing intracranial pressure. And one of the most common ones is the sixth cranial nerve. And those are the nerves that help your eyes sort of look outward. So each eye can look this way. And so a lot of times people can get an inability to look to one side or to the other, or an inability to look laterally, and that's called sort of that's called like a cranial nerve 6 palsy, or a lateral gaze palsy. So a lot of times we see that in the setting of people that have high intracranial pressures. And so the sixth nerve is the one that's most commonly, that's of the 3 nerves that control the muscles that move your eyes, not your vision, not your optic nerve. The sixth nerve is the one that's most commonly affected with increased intracranial pressure. So if you are I'm sure Pierre has seen this as well in patients with sort of fulminant IIH symptoms. Not only are they coming in with all of the symptoms that he just mentioned, and declining vision and headaches and whatnot, but oftentimes when you examine them, they'll often have an inability to look laterally, either with one or both eyes, and they'll also complain of what that can sometimes result in some double vision. I don't know, Pierre, what do you think?
Yeah. So the 3 main eye symptoms that IIH patients have is, first, papilledema is very well known, with a risk of progressive visual field loss, where your vision narrows. The second sign is diplopia, due to cranial nerve, oculomotor nerve palsy, and number 6. And the third is called transient visual obscuration, where you lose vision in one eye, rarely both eyes, but at least one eye, for a few seconds, 5 to 10 seconds. And that's due to the high intracranial pressure into the brain, and most probably. And it's a sign that you should be aware of, because it's a sign of transient ischemia in the optic nerve. So that's a sign that requires treatment. That has to be addressed, really.
Thank you very much. Just a little side note, a lot of patients, because we know this predominantly affects women, are fertility and hormonal related, a lot of pregnancy questions. I promise if we cannot answer those questions, we will try to find an expert in that and get you the right information. But there is one question I think maybe Dr. Gobin could answer, from Miss Liz Land. Is there a relationship between IIH and hormones? She has noticed the severity of symptoms increasing a few days before her ovulation or menses.
Definitively, absolutely. And it's we know that IIH strikes mostly women, and that are maybe 20 to 50-year-old, in their reproductive age, likely overweight. And so it's certainly it's related to estrogen production. We don't know why and how this happens, but it's definitively related, yes.
Thank you very much. A couple of questions are medication related, if either of you have experience with this. For example, does Topamax cause tingling in the hands and feet? And if yes, will it ever go away?
Well, yes, it goes away, but with stopping it. Topamax? No,
Topamax.
Topamax, I don't think so. Diamox does.
Okay.
Yeah.
Diamox or acetazolamide does. No, Topamax can have a bad problem with acquisition of new memory, where many students who are placed on Topamax, or every adult, that need to learn a lesson, to learn a new trade, something like this. And many patients on Topamax will just lose this function. It's entirely reversible with stopping the Topamax. The tingling in hands and feet, that's a typical secondary effect of acetazolamide or Diamox, and it also goes away with stopping the medication.
Thank you very much. A question for Dr. Brian Snelling. Can IIH cause Valsalva pain? Miss Tanya says, I have never had it until recently. It feels like ice picks being stabbed in my head, and I do not get a lot of headaches compared to some others I have spoke with.
Yeah, I'm assuming what you means by Valsalva pain is, any sort of inspiratory hold. So if you're holding your breath, or you're bearing down, or you're straining, certainly any of those maneuvers, we know increase intracranial pressure. So if you already have increased intracranial pressure as the baseline, and then you do something such as bend down or strain to have a bowel movement, hold your breath for a while, maybe lifting something heavy. Any of those things can certainly increase your pressure, and that can definitely lead to triggering bad headaches and things like that. So I think that's completely within the realm of reason to be a triggering event for headaches in the setting of IH.
Thank you very much. This question is, I'll give it to Dr. Gobin. This is from Mr. Matthew Ash. It says, hi, why are doctors or specialists so reluctant to even want to try and assist with IIH? It's almost like they don't recognize it or seem to know about it.
That's a big question. We had a talk about this, Edith, about overweight young person whose all symptoms were dismissed, and the only answer of the physicians was just lose weight and your problem will go away. Do you remember, Edith, with what doctor it was? I think it is one of our IIH Hub podcast.
Let me think about it, and if I can figure it out,
Yeah.
I'll mention it before we end the session today.
Yeah. But it's really a problem, yes, with IIH patients, that their symptoms are dismissed or ignored, the problem is that we don't have the perfect treatment. We know our medications are very imperfect. They relieve partially the symptoms, but they do not address the cause of IH. The surgical treatments that we have are effective, but they are surgical treatments, so we have to reserve them to patients with severe symptoms who do not tolerate the medical treatment. And same thing, they are not perfect. The shunt will relieve some pressure into the brain, but will not reestablish flow into the interstitial fluid. the stent will relieve the pressure into the venous sinus due to the stenosis. So it will improve the venous flow drainage of the brain, but same thing, it doesn't address the primary cause of IH. That may be why, and many physicians do not know this disease well enough. It's still a rare disease, so many physicians do not know how to treat it, do not know the range of medical treatment, do not know when to address a patient for a surgical treatment, etc., etc. Brian, you have treated many.
Yeah, I mean, yeah, I think I agree with everything Dr. Gobin said. I think I would offer my own perspective on it is, for another example of things that both he and I treat are brain aneurysms, right? If someone's found to have a brain aneurysm, they get some sort of imaging study, the radiologist reads it, they have a brain aneurysm. The doctor that ordered it, the primary care doctor, then sends them to a neurosurgeon, a neurointerventionalist, a neurointerventional radiologist, and that's very easy, right? So like that's a very straightforward pathway from a patient that's found to have a disease or a problem to somebody who is able to treat that and doesn't need to send that patient anywhere else for treatment. IIH is very different because essentially patients, there's a lot of people who don't have a complete understanding of the disease and maybe only understand it within their local specialty. And two, some patients can enter the healthcare in a lot of different access points, right? If the patient has visual issues, right, that's they usually see an ophthalmologist or a neuro-ophthalmologist, and that's a great place, right? Then you can get sent to the pathway of a neurologist who can start them on medications, and eventually they can get to a neurointerventionalist or a neurosurgeon. But sometimes the neurologists don't know about venous sinus stenting or whatnot, right? So there's a lot of ways this can fall down. Imagine if your presenting symptom is brain fog and you go see a neurologist and you're not complaining of papilledema or vision loss. They may think it's due to something else, or you may say I'm having some brain fog and pulsatile tinnitus, right? Those are very different for them than say, okay, when I think of IH, I think of patients who are losing their vision, right? So it's a constellation of symptoms that encompasses a lot of different subspecialties, and unfortunately in medicine we're all very siloed in what we think about and how we treat patients, and it's often difficult to find a physician or a specialist who can sort of quarterback or who can captain the ship to both diagnose the patient and then get them put on a path to get to the right treatment, if that makes sense. In addition to like Pierre said, it's a rare disease, and as you've seen, as he mentioned, in two facets. One, venous sinus stenting is relatively new in terms of a treatment option. So there's a lot of people who have been in practice for years who've never heard of that. That's never been an option for them. And then additionally, when we think about the pathophysiology of it, talking about lymphedema and the fact that venous sinus stenosis is more a symptom of the disease than the cause of it. Those are all things that we're just learning. So it's a lot of this is just an evolution.
Thank you. As we all know, there has been some information in the past that IH has been mainly affecting women with a higher BMI. And some studies have shown as little as 10% of body weight loss can improve or even place IH in remission. But as we've learned from Dr. Sofia Cienfuegos and from Ms. Rebecca Washuta and many other people, that sometimes losing 10 pounds is not as easy as people like to make it to be. So one of the questions we have in our chat is, if Dr. Gobin, if you could please discuss the new findings about GLP-1 receptor agonists being used to treat IIH.
So there was a study, a company called Invex Therapeutic, an English company that was repurposing GLP-1 agonist for the indication of IH. And they started a clinical trial, and after a huge clinical trial, huge effort from the private industry. And I think they enrolled 8 or 9 patients within 1 year. So they stopped the trial because they did not see a financial benefit in pursuing the clinical trial of a GLP-1 agonist in IH. So that's really a bad news for the field of IH. So IH is a rare disease, and there are not many pharmaceutical companies that are going to do the financial effort to to try a drug specifically for this indication, because there are just not enough patients for a private pharmaceutical company, that warrant the cost of doing the clinical trial. So there have also been clinical trial of bariatric surgery for IH. And we saw that the patients who improve their IH symptoms when losing weight were the patients who had bariatric surgery. But even they needed to have Roux-en-Y, which is the most aggressive form of bariatric surgery. You know well, Edith. And yeah, the patients who lost, I think it was 25% of their BMI, of their weight, then they improved their symptoms. Not tremendously. If you, I know because I compared, compared the rate of improvement of intracranial pressure after bariatric surgery compared to after stent. And the improvement of the intracranial pressure after bariatric surgery, after the most aggressive bariatric surgery, was still less than the improvement of intracranial pressure after stent. So it means that, and I use bariatric surgery, I know that the question was on GLP-1 agonists, but I use bariatric surgery because the best way to lose weight very fast and to lose a lot of weight is bariatric surgery. And yes, it helps, but it doesn't help so much. And so we have this hope that GLP-1 agonists, patients are going to lose. GLP-1 agonists are also very good at losing weight. They have side effects, we don't know how long you can use them, how many years you can use them, because it's really a new treatment. But that's a very effective way to lose weight. But you have to lose a lot of weight to treat IH. It's not by losing 5 or 10 pounds that you are going to cure IH. Now you can improve symptoms, and this is probably that would be enough for some patients, but it's not like the magic wand.
Thank you very much. This question goes to Dr. Brian Snelling from Mr. Kasim. After having a VP shunt surgery 1 month ago, I still get mild migraines, stiff neck pain, and tension headaches. Does this mean the VP shunt isn't working? Also, does neck spondylosis influence shunt or IH in general?
Yeah, both good questions. I'll answer the second question first. Neck spondylosis is usually not related to the shunt at all or anything like that. It's just a finding of the bones of the neck. So not related to a shunt placement, not related to IH. After having a shunt surgery, I still get mild. Certainly, depending on the reasons the shunt were placed, if it was placed for IH, certainly patients can still have some headaches and some neck pain. Again, for a lot of patients, depending on the reason it was placed, the goal of surgery is vision preservation, improvement and preservation, right? We don't want the vision to get worse. We like for it to get better. Those are the goals of surgery in someone who has failed medical therapy, who has worsening vision, maybe fulminant IH, and they get a shunt. Secondary goals are relief of other symptoms. But as I tell my patients, look, if we get to the point where we have to do a shunt, if in 6 months from now your vision has improved or your vision has remained stable and the shunt is working and you still have other symptoms, that we know that's in many cases the best a shunt can do. It can't relieve all of the symptoms. In terms of postoperative recovery, generally, again, without knowing the specific, it's difficult to say specific to that person's case, but generally we like postoperative discomfort to improve and to be trending down. So every patient's different. Every patient's surgery is a little different. Some people are they have a little bit more discomfort after surgery, but generally what we like is we like the symptoms to be improving day over day. Certainly if, 2 weeks after the person was doing well, and in the past 2 weeks, they feel like their symptoms have began to escalate, then obviously that's a reason to have another visit with your neurosurgeon and say, hey, it seems like things are going in the wrong direction here.
Thank you very much. A question that I think is, a good one for both of you. It says, is there any data on how many med schools actually teach IIH?
I don't know if there's any data on it. I don't know, Pierre, maybe you know better than I do, but I don't know if there's any specific data about how much it's taught. I can certainly tell you that it used to be called pseudotumor, and that at least when I was in school, that was taught. But as I explained earlier, this has all been a process and evolution. So a lot of what we learned at the time, whether it was what we call the pathophysiology, meaning what's the underlying cause of this, and certainly the treatment options have all changed. So a lot of our ability as clinicians or as physicians to treat patients like this is to stay up to date with the latest options, and the latest understanding of the pathophysiology.
Thank you very much. One question from Kelsey is, for patients like herself who are not overweight when diagnosed, are disease mechanisms likely different than a quote unquote typical case? And if so, should treatment be approached differently?
So I can start. Yes, treatment might be approached differently. I think that if this patient is not overweight, he or she may be in the 10% of patients that are not overweight. Those patients are even more likely to have a venous sinus stenosis, a significant venous sinus stenosis, than the typical IIH patients. And they are more likely to have the symptoms improved by venous sinus stenting.
Thank you very much. And
once again, I want to say once again, no venous sinus stent is FDA approved in our country at present, and this is really a big problem. So when I don't want to market venous sinus stent. I don't want to advertise for it because it's not FDA approved. I mean, it has been performed for, I think the first case was performed in 1994 by Dr. Marks in Stanford. And so the technique is 28 years old. However, because it's a small market, small population of patients, no stent is approved. So we physicians, we use stent safely in general. Maybe the complication rate of stenting is about 1 to 3% if you read what is reported in the literature, but it's still a risk.
Thank you very much. Well, we are closing in on our hour webinar, and to your point, Dr. Gobin, literally a lot of the chat is about venous sinus stenting. So definitely our patients are very informed, and a lot of them have had stent placement. So I think they are very grateful and appreciative of you kind of, talking about that, because, hopefully in the future there will be some sort of approval, but we appreciate the information. If there's any closing comments you guys would want to add before we thank everyone, I'll give you a minute to, say anything before we close the chat. No.
No, I mean, it's thank you for the opportunity. I always learn something when I spend an hour with Pierre, so happy to have had the time with you guys.
I will say only one thing is that more and more there are centers in this country where IH is being treated by a multidisciplinary team, and I encourage patients with IH to find in their vicinity teams that that will treat them, so that they are not seen only by a neuro-ophthalmologist that will see that will just look at the eye, or by a neurosurgeon or neurointerventionalist who thinks only that surgical procedures are going to treat IH, or and that they have effective medications, etc., etc. So those multidisciplinary team, I don't think there are many. I mean, at Cornell, we really try to treat patients like that, with being taken care of by a multidisciplinary team, but try to have your care being done. IH by such a center. IH is a rare disease. Not many physicians master all the aspects of IH. And the most significant, for me, the most significant burden of IH is the poor quality of life that our patients have. And that's what we should improve.
Thank you both very much for your time. Thank everyone for your attendance today. I promise you I did not ignore some of the questions that went unanswered, but it to me is a reflection that there's a lot of, to your point, Dr. Gobin, is seeking, educating yourself, being an advocate for yourself, knowing some of the verbiage, keeping track of, your journey, so that when you present it to these specialists and physicians, it can hopefully streamline things for you. And we do have a website full of resources. We have a provider page of some of the people we've featured in the past that we know actively treat IH or do research in it. A lot of physicians do telemedicine too. So even if you live in a certain state, I know someone asked about Delaware, Philadelphia, they may see you maybe in New York, for example. But you can connect with us on social media. You can also message us through our newsletter or our email. And we will be announcing our future webinar, hopefully in the next few weeks, for hopefully October or November. And we look forward to seeing you all there.